Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. On the next few podcast episodes, I will discuss mediastinal masses, beginning with a quick overview of mediastinal masses, followed by questions and answers pertaining to anterior mediastinal masses. I will make a free downloadable study guide on this topic of anterior mediastinal masses available on my website, theradiologyreview.com, so please go ahead and check that out if that is helpful for you. Without further ado, let's get into the questions and answers for this episode. First question: what are the four divisions of the mediastinum? The four divisions of the mediastinum are the superior, anterior, middle, and posterior mediastinum. Note that although there is a superior mediastinum, there is typically no inferior mediastinum. Next question: what are common differential considerations for anterior mediastinal masses? We will go through this in greater detail in this episode, but some common differential considerations for anterior mediastinal masses include lymphoma, thymic hyperplasia, other thymic processes, germ cell tumor, lymphangiomas, pericardial cysts, and thyroid processes. Next question: what are common differential considerations of middle mediastinal masses? First, lymphadenopathy is really common in the middle mediastinum, and that can include lymphadenopathy from granulomatous disease, metastatic disease, and lymphoma or leukemia. If mediastinal nodes are calcified, consider tuberculosis, fungal etiologies, osteosarcoma, sarcoidosis, and more chronic granulomatous processes such as histoplasmosis and coccidiomycosis, depending on the geographic location. Foregut duplication cysts are also a differential consideration of middle mediastinal masses. Next, what are common differential considerations for posterior mediastinal masses? In the posterior mediastinum, think neurogenic processes. In the first decade of life, posterior mediastinal masses are most suspicious for neuroblastoma on a board exam. Posterior mediastinal masses in the first decade are most commonly malignant, such as with neuroblastoma. In the second decade of life, posterior mediastinal masses are most commonly benign, and differential considerations include neurofibromas, ganglioneuromas, extramedullary hematopoiesis, and schwannomas. Next question: what is the Hilum overlay sign, and how can this sign help you localize masses in the mediastinum? The Hilum overlay sign is basically the concept that a hilar mass will obliterate the silhouette of the pulmonary vessels on an AP or PA chest radiograph. If you see the edges of the pulmonary vessels on the chest radiograph separate from the mass, then the mass is likely to be in the anterior or posterior mediastinum and is less likely to be hilar in the middle mediastinum. Note that additional signs to consider on chest radiographs in terms of mediastinal location are obliteration of the retrosternal clear space, effacement of the ascending aorta, and displacement of the anterior junction line for anterior mediastinal masses. Don't forget about the lateral chest radiograph, as that can be extremely helpful to localize a mass to the correct mediastinal location. Next question: what are common differential considerations for mediastinal masses that invade the lung, pleura, or chest wall? Differential considerations include malignant entities such as esophageal carcinoma, lymphoma, malignant germ cell tumor, or metastatic disease. Lung masses that invade the mediastinum include primary lung malignancies. Note that pleural masses that invade the lung and or mediastinum include pleural metastases in addition to malignant mesothelioma. Next, true or false? Mucoepidermoid carcinoma of the trachea is more likely to invade the mediastinum versus adenoid cystic carcinoma of the trachea. The answer here is false. Adenoid cystic carcinoma of the trachea is more likely to invade the mediastinum compared to mucoepidermoid carcinoma. Hopefully you got that question right. That is a concept I've covered on a previous podcast episode on the trachea. Let's go ahead and move on specifically to anterior mediastinal masses. Structures in the anterior mediastinum include the thymus, lymph nodes, the thyroid, and the ascending aorta and pulmonary arteries. The thymus and lymph nodes are the tissues that give rise to most anterior mediastinal masses. That leads us into the first question for anterior mediastinal masses. What is the 4 T's mnemonic? And that is T like toy. 4 T's mnemonic for anterior mediastinal masses. The 4 T's mnemonic for anterior mediastinal masses has some variation, but includes something like thymoma, teratoma, thyroid, and terrible lymphoma. I think this mnemonic is annoying. For example, terrible lymphoma, but it is also memorable, so I am repeating it here, and it can be helpful. If you see an anterior mediastinal mass, think of thymoma and other thymic entities, teratoma, thyroid entities, and terrible lymphoma. Next, is thymoma or lymphoma more common in young females with a large anterior mediastinal mass? What about in females over 40 years of age? In young females, a large anterior mediastinal mass is lymphoma until proven otherwise. However, in a female greater than 40 years of age, thymoma becomes a top differential consideration. Note that thymoma classically does not cross the midline and only occurs in one lobe of the thymus. Next, are germ cell tumors of the mediastinum more common in males or females? Mediastinal germ cell tumors are more common in genetic males. Note that anterior mediastinal germ cell tumors are most commonly teratomas in something like 75% of cases. Next, from what anterior mediastinal tissue do germ cell tumors derive from? Germ cell tumors derive from the thymus, which has pluripotent cells, which can be the cells of origin for germ cell tumors. Next, how can one tell the difference between thymic rebound and lymphoma on MRI? Classically, thymic rebound may show drop of signal on out-of-phase MRI imaging, as thymic rebound and the normal thymus is fat-containing. Lymphoma will not have signal dropout on out-of-phase MRI images. Both thymic rebound and lymphoma can have abnormal increased uptake on FDG PET-CT, although lymphoma overall tends to have a higher degree of uptake on FDG PET-CT compared to thymic rebound. Next, what are some common etiologies of thymic cysts? Thymic cysts can be congenital or acquired. A classic association is development of thymic cysts after thoracotomy, And thymic cysts can also be acquired with HIV or chemotherapy. And that is a high-yield concept for radiology board exams. If you see thymic cysts in a patient, you should think, does this patient have HIV or chemotherapy, or have they had something like a thoracotomy? Remember that thymic cysts tend not to have associated solid components. If you see mixed cystic and solid components within a thymic lesion, think thymoma, lymphoma, or germ cell tumor. If there are cystic components with septae that clearly enhance, germ cell tumor may be the top differential consideration. Next, does calcification of a thymic mass typically denote more benign or more aggressive disease? Calcifications involving a thymic mass typically denote a more aggressive disease process. Thymomas can be benign or non-invasive, invasive, or malignant. Thymic carcinomas tend to be invasive and occur in middle-aged to older individuals most commonly. However, curvilinear calcifications along the capsule of a thymic lesion is most associated with a calcified thymoma, whereas stippled calcifications within the mass are more associated with thymic malignancies. In general, malignant thymomas calcify more commonly than benign thymomas. Next, why might a radiologist suggest imaging of the abdomen in cases of malignant thymoma? If malignant thymoma metastasizes, pleural metastases are common, in addition to drop metastases to the retroperitoneal space in the abdomen. Therefore, abdominal imaging may be of benefit to look for those drop metastases in the retroperitoneal space. Next question. What is a very classic association with thymomas and a specific neurologic autoimmune illness? It is key to remember the classic association between myasthenia gravis and thymomas. If you have a thymoma, there is something like a 50% chance that you also have myasthenia gravis. However, only something like 15% of patients with myasthenia gravis will also have a thymoma. The association is still strong, so remember the classic association between myasthenia gravis and thymomas. Next, what are characteristic imaging features of a thymolipoma? Thymolipomas have lots of fat, with the abundant fat interspersed between soft tissue components. Thymolipomas are classically asymptomatic and may be found incidentally, and a thymolipoma can become quite large before one might see it. Thymolipomas can be thought of as being a soft tumor that may extend around adjacent mediastinal structures, and the prominent fat density components within a large mass should make you consider the possibility of thymolipoma, which is curative with surgical resection. Next question. Kleinfelter syndrome has a classic association with what mediastinal mass? Remember that Kleinfelter syndrome is a sex chromosomal process which is associated with having 47 chromosomes instead of 46, most commonly 47XXY. Kleinfelter syndrome is associated with an increased rate of germ cell tumors, most notably in the mediastinum, in addition to other entities that include omphalocele and choroid plexus cysts. More specifically, Kleinfelter syndrome is commonly associated with mature teratomas in the mediastinum. Note that immature teratomas are more common in males, but mature teratomas are equal between the sexes and associated with Kleinfelter syndrome. Next question. What thyroid processes can be included in the differential consideration of anterior mediastinal masses? Thyroid cancer and thyroid goiter can both occur in the anterior mediastinum. Remember that thyroid processes can involve the anterior mediastinum, and thyroid is one of the 4 T's of anterior mediastinal masses, as we previously reviewed. Last question. What is the most common location of a pericardial cyst? Pericardial cysts are benign congenital anomalies and most commonly involve the right anterior cardiophrenic angle. Pericardial cysts can involve the anterior or middle mediastinum and can be found basically anywhere around the heart, but the classic location is the right anterior cardiophrenic angle. Remember that pericardial cysts should classically not enhance and demonstrate fluid attenuation, and these are benign lesions. That concludes this podcast episode. As a reminder, a free downloadable study guide on this topic of anterior mediastinal masses is available at theradiologyreview.com, so please check that out if that is helpful for you. I will continue my discussion of mediastinal masses on the next podcast episode, so please tune in to that. Please send any episode suggestions to theradiologyreview@gmail.com or at RadRevPodcast on Twitter or Instagram. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.